This is about CT abdomen plain and post IV contrast done in a 75-year-old lady. Please give the two differential diagnoses due to the classical findings in the given images. Please ignore the simple cyst seen in both the kidneys. If you want more time for the full assessment and for the diagnosis, pause the video and go back to assess all the images. Really, it needs more time to evaluate all the CT images and to give the two classical different diagnoses. For experienced radiologists, this could be spotters, but for the residents, I think the images and the discussion will be highly informative. Within few seconds, I'll give you the findings and the twin diagnosis. Are you ready? Let's go. In the upper and mid abdomen, there is a large oval hypodense lesion in the body and tail of the pancreas with multiple calcific foci. The lesion shows multiple small and large cystic lesions with enhancing septae. The lesion is bulging the anterior abdominal wall near the midline. The splenic vein is compressed and displaced posteriorly by the lesion. The head and neck of the pancreas appear normal in size and caliber with homogeneous enhancement. There is no dilatation of the pancreatic duct. Incidentally detected cortical cysts are seen in both the kidneys, with the largest exophytic cyst from upper pole of the left kidney. In the lower abdomen of pelvic cavity, the levator ani muscles appear thickened for this age, with a hypodense lesion within the levator ani muscles below the pubic symphysis, and that lesion appears filled with contrast later. The bladder wall appears thickened with no nodularity or mass or any calcific foci. Remember, all these things are seen below the level of pubic symphysis, which has not been given here. Now I have to give the history of this 75-year-old lady. The patient came in the outpatient room questioning the consultant, why I am having a bulging mass in the introitus while I pass urine for the past few months. Is it due to a cancer, as one of my relatives had breast cancer and died recently? That's why I am here. The surgeon felt a mass in the upper abdomen and the physician clinically diagnosed one in the lower abdomen. Ultrasound abdomen was done and both were right. Ultrasound abdomen revealed surprisingly a pancreatic multicystic mass in the upper abdomen, but in the lower abdomen her uterus and the bladder could not be seen transabdominally, and the 75-year-old lady refused transvaginal study. Anyway, CT abdomen is very much needed for the assessment of the upper abdominal mass. Then CT was done to clarify all the queries. With the given CT images, the most likely diagnosis of the upper abdominal mass is cystic neoplasm of the pancreas, probably serous cystadenoma, by the characteristic CT appearance. Rare differential diagnosis of either infected cirrhosis or atypical pancreatic tuberculosis might also be in our mind. Additional findings in the lower abdomen are highly suggestive of severe cystoscopy in the pelvic organ prolapse, with the classical finding of presence of the bladder neck, which has been filled with contrast below the level of pubic symphysis. The mass was surgically removed, and this was histopathologically proved to be as a pancreatic serous cystadenoma. I am giving the surgical specimen of the removed pancreatic serous cystadenoma with the spleen included. Even the removed uterus and the ovaries are also given with no malignant changes in the uterus and ovaries histopathologically. Now, for discussion, I am giving the table of various types of cystic neoplasm in the pancreas. Common ones being serous cystadenoma, mucinous cystic neoplasm, and intraductal papillary mucinous tumor, which can be abbreviated as IPMT. Uncommon rare cystic pancreatic neoplasms are also given. Please go through that as the differentials. I am going to discuss only about the serous cystadenoma afterwards. Serous cystadenoma is a common cystic neoplasm of pancreas and can be classified radiopathologically as polycystic type, honeycomb type, and oligocystic type, with the polycystic type being the most common one. In ultrasound, multiple cysts of cluster of grapes pattern can be seen in the pancreas with posterior acoustic enhancement, even if the cysts are too tiny to show cluster of grapes. They are very diagnostic of serous cystadenoma on ultrasound. In CT and MR, there is external lobulated mass with Swiss cheese pattern of enhancement, very important Swiss cheese pattern of enhancement, and the CT shows few calcific foci. All of these findings are greatly in favor of serous cystadenoma. In our case, CT revealed few calcific foci in the plain CT and shows grape-like cluster of cyst which could be seen especially in the venous phase of IV contrast with external lobulation of the mass. All of them are classical for the diagnosis of serous cystadenoma. Presence of central stellate scar is an additional feature for the diagnosis of serous cystadenoma even if there is no calcification, and this can be diagnosed on CT and MR, usually seen after late enhancement in the grape-like cluster of cyst. In this decade, endoscopic ultrasound is the earliest diagnostic tool with all the sonographic findings as described above in the presence of central stellate scar, which is almost pathognomonic for serous cystadenoma. Radiopathological types of serous cystadenoma already described, like polycystic type, honeycomb type, and oligocystic type, and the polycystic type being the most common. And our case is also polycystic type of serous cystadenoma and is the commonest one and can be diagnosed easily on CT and MR. Even honeycomb pattern doesn't give much trouble for the diagnosis, but if the cysts are smaller in size and the cystic lesions are less in number, the benign oligocystic type of serous cystadenoma may not be distinguished from pre-malignant type of mucinous cystadenoma. Please remember this fact. Less common infected pseudocyst and rare isolated pancreatic tuberculosis might not be differentiated from serous cystadenoma radiologically. When there is evidence of localized or distant invasion of the pancreatic cystic mass, possibility of serous cystadenoma is virtually excluded. We will discuss about the cystocele in pelvic organ prolapse now. Please see the normal CT anatomic landmarks of pelvic floor in a healthy elderly woman described and labeled with bladder, obturator internus, levator ani muscles, and ischiorectal fat. In the practical point of view, when bladder is seen 10 mm below the lower edge of pubic symphysis, possibility of cystocele might be considered. Bladder could be seen up to few millimeters below the pubic symphysis in obese elderly or in patulous or multiparous women. We will now discuss about the types of pelvic organ prolapse. It's very common and routinely called as cystocele. Less common ones are rectocele, enterocele, and usual one is the uterine prolapse, and if the entire uterus has been prolapsed, it is called as procedentia. All of the above types can occur during mechanical stress or during cough at the early stage and may become permanent later if untreated. Now we'll go to the stress incontinence, which might be the predisposing factor for the pelvic organ prolapse later. In the early stage, she might consult the doctor because of stress incontinence, which is due to urethral hypermobility, and this might be there for many months to few years before the clinico-radiological diagnosis of cystocele or pelvic organ prolapse. In cases of stress incontinence, urethral hypermobility can be diagnosed earlier by dynamic MRI and by ultra-high resolution ultrasound, as this stress incontinence might occur in pregnant women or after vaginal delivery, or it can be due to abdominal or pelvic mass or after abdominal or pelvic surgery. Lastly, don't forget that the fact of vaginal wall prolapse, which can occur after hysterectomy. So we are in the end of the session. We discussed about severe cystocele in a 75-year-old lady due to the fear of malignant tumor, and incidentally a large benign serous cystadenoma in the pancreas was diagnosed. Okay, so that's end of the session. We have discussed in detail about the pancreatic serous cystadenoma and about the pelvic organ prolapse. If you have any queries, please mention your thoughts in the comment section. Thank you very much for patient hearing. If you are interested in the entire quiz list, you can click the blue colored R button and then go on to the respective quiz. Take care. All the best.